So I'm going to talk about shared decision-making and patient engagement in IBD. So this is kind of the objectives. I'm going to go past that. So why shared decision-making? Why do we need it? So the treatment options getting better, right? We're getting better meds, and the decisions, however, are getting a little bit more difficult. So the step-up approach, and this is the first one here, the step-up approach to treatment was not an effective approach, but seemed to be, easy to understand for patients, starting out with the lower risk type meds and then moving up. But what we learned is the biologics were reserved for sicker patients. You had to move through the process before you could get the medication that you really needed. And it was introduced after all other treatments, so that were failed or that were steroid dependent. So the new biologics are standard treatment at this point. Top-down approach comes to mild to moderate disease. They start a little bit earlier. It's initiated earlier and is based on risk assessment. And the combination therapy with an immunosuppressant is also often added. But there's also barriers that exist in widespread use, and these are patient and provider. So you have financial concerns, and I know everybody here understands that process if you're calling in for pre-ops, which is a huge thing. And patients also worry about the side effects, right? Lymphomas or cancers. And combination therapy with an immunosuppressant as well. I'm sorry, I'm missing down at the bottom. I'm seeing on a small screen here. Patients feel they do not deserve the strong therapy early on in their disease course. You can understand that. Then there's the provider who's also not educated on the risk, or they're scared to start a biologic. And we've seen patients like this who come and say, well, they kind of talked about it, but their provider didn't really feel comfortable. And so finally, I'm here and I'm getting another opinion. And then the patients are more educated about the risks and benefits of IBD treatments than ever before. But they're doing this crowdsourcing, going online, looking at different websites for different, hearing different things about, this is bad or that's bad, or they're getting actually the wrong information, or they're going to their friends, etc. And then we have what we're saying here is that to engage patients, we need to promote the practice of shared decision-making. That's what we got to do to get through this here to help us, providers, as well as patients. So what is shared decision-making? It's a process of interaction with patients who wish to be involved with their care, and that's very important. They need to be involved with their healthcare providers in making medical decisions. Providers are responsible to inform and recommend treatment, but the process of how to act on this is shared with the patient. It has to be the provider-patient cooperation. The goal, we want to enhance patient involvement on the basis of the available evidence, facilitate evidence-based patient choice. So we're moving from an informed consent to an informed choice. So what are the goals? Overall goal is to involve patients in decisions and educate them on all their options, engage them in treatment decisions to optimize the chance that the chosen therapy matches their personal preferences. And that is very key. Personal preferences is an active part of this whole process. So this leads to patient confidence in their treatment plan, adherence to chosen therapy because they've bought into this, they understand it, increased quality of life because if we get them engaged early on in the process, they're going to be adherent, and hopefully they're going to feel better and have a better quality of life. And this also improves the patient-provider relationship They're talking, they're engaging on an ongoing process at various intervals. And often they're much happier with their relationship with their providers. So decision aids, I think we've all seen them out there. There's various ones. They're usually standard tools used to promote the shared decision making. And they also are developed to prepare patients for specific treatments. They're balanced presentations. They should comment on either way about whether you use the med or you don't. But it also just kind of talks about the needs of the patients with their provider. And they present evidence-based information, definitely in patient-friendly terms so that they can understand, not in medical terms. And it includes, once again, personal preferences with their provider. Part of the process of decision support is not meant to be used on its own, meaning it's not going to replace the provider talking with the patient. And well, here's explanation of your risks and benefits, and here's the meds. No, the provider still needs to sit down. It's a complement to the decision-making process. And here's one that is on the CCFA website. It's Empowering Crohn's Patients with Interactive Decision Aids. And this is part of Corey Siegel's, and I know if you heard him talk yesterday, they're doing some studies with this, and he's initiated it, and so far they've been having some good response. Here's one, and maybe you've all seen this, the risk of developing Nonhodgkin's lymphoma. And here is the risk without medication. And here's the risk of lymphoma with immune suppression. So we've all gone through and seen that. And how many of your patients say, that's me? But that's me there. That 1, 2, 5, whatever, that's me. And we do have some patients that say that. So what do we say to them? Number one, without medication, that is a much higher risk than this most often. We're also monitoring you all along this process so that we get an early on diagnosis on any of these complications, doing all of our vaccinations early, all that pre-testing stuff that we do as well. And then, I don't know if you've seen this grid, it's out there as well. It's on the various medications, it's on the immunomodulator, the anti-TNFs, and talks about combination therapy. And on the side, you see the different questions that you could sit down with your patient. And here, it's just the second page of it, but it's a real nice question and answer for your patients. But again, you should sit down with the patient and go over it. Here is sometimes what we use in surgery. You can see the chance of needing surgery for Crohn's disease, how you can demonstrate 40%, 60%, 70%. Patients sometimes need that visual to give them an understanding. So here's some decision sharing criteria. It's a basic criteria. There has to be equipoise in the options, meaning the best option is not clear. The stakes are not minimal, so there has to be some significant consequences to it, where there is some, decision-making and thought process that has to go on. It's not just a simple, well, yeah, that's the answer. No, there has to be a little, like it says, there has to be a little differentiation that you need that extra discussion. And it has to be, once again, are you getting my word preference sensitive that I'm trying to relay over and over? That is so key in decision-making. So there's more than one appropriate option that patients will decide based on what is right for them, depending upon the balance of risks and benefits. So here's some preference-sensitive and risk-benefit decisions in IBD. Monotherapy versus combination, anti-TNF plus ethioprin. That can be a discussion. Top-down versus rapid step-up therapy diagnosis. Medical treatment versus surgery for steroid refractory ulcerative colitis. A biologic versus non-biologic therapy. An ileo J-pouch versus an ileostomy in ulcerative colitis. Colectomy for low-grade dysplasia versus continued colonoscopic surveillance. Infliximab versus adalimumab, certolizumab, Pegol for Crohn's disease. And then your natalizumab versus second and third anti-TNF agent in Crohn's disease. So these are all can be some preference sensitive. You're going to sit down, you're going to talk with them. They're going to kind of decide, well, yeah, I want to go on a thiopurine, or no, I have issues. And they're kind of like saying no. And then you're presenting all the material that you know says, hey, combination is better. And they go, I don't know. So, okay, they go on monotherapy. We do a trial of that and see how it goes. So all of those have equipoise to them. These are not preference sensitive, because these are quality indicators or standards of practice that we must do for our patients. The TB testing prior to initiating an anti-TNF, assessing Hep B prior to initiating a TNF, testing for C. diff during a flare of colitis, vaccinations for immunosuppressed patients, smoking screening and cessation discussions, the anti-prophylaxis daily while hospitalized. This has to be done. Corticosteroid sparing therapy, we talk about that, but how many patients also say, but I really feel good on steroids, so I kind of want to stay on them, you know? So it's like, no, cannot do that. We have to have an exit strategy. Assess bone loss for corticosteroid-related iatrogenic bone loss. So these are all things that are pretty much standards of care for IBD. They're not preference sensitive. So is decision-making right for all? Not all patients are interested in it. Not all patients are suitable for it. And not all decisions should or can be collaborative. So here, nurses and the IBD providers need to identify the extent of the role desired by the patient. We have to sort of get a feel for that, and we do when we're sitting in a room with the patients. You kind of get the feel whether they're kind of like there to just get information, or you know what, I'm here and I'm really not ready for surgery, or I'm not going to go on that therapy, or I want to try diet. You can tell where they're at in this process. And this will determine which decisions require their input to provide the best patient care. So once again, you want to match the decisions to the patient preference. So what are you going to do? You're going to ask them after your discussions, your education, what do you think? What do you want to do? What are your fears? Get them involved. So probably a lot of you have seen the Degner and Beaton's pattern of decision making. You have the active patient who says, I prefer to make the treatment decisions themselves. I prefer to make the final treatment decision after seriously considering what my provider thinks. Then you have the collaborative one who says, I prefer that my provider and I share that responsibility in deciding which treatment is best for me. And then you have that passive provider controlled. I prefer my provider to make their treatment decisions, but only after my provider has seriously considered my option. I prefer to leave all treatment decisions to my provider. Have you all seen patients in all three of these stages? Yes. So how important is IBD patients, how important is it for them to be involved in their medical decisions? And this is a study that was done, and as you can see here, most IBD patients think it's very important to be involved. 81%, 17 thought it was quite important, and then there was that 1% who thought it was totally unimportant. So our patients, they do want to be involved. And here's a study that looked at how much risk are patients with Crohn's disease willing to accept. And you can see the maximal acceptable risk rate is on the left, and then you can see here's disease start and end states, and the most severe to patients that are at that point nearing remission, they are very much willing to take a higher risk with more severe disease and greater expected benefit. So the more sicker our patients are, often they are willing to take that risk. And here's what goals are most important to our patients. I think this is interesting too and important for you to know, that those top ones are the complete resolution of symptoms, 72%, avoiding an ostomy, staying alive, avoiding surgery, and not missing work and school was very important. to the patients with ulcerative colitis. And this kind of went along with Corey Siegel's talk yesterday too, which he was talking about, and this was part of his study. The Crohn's patients are looking for complete resolution of symptoms, avoiding anostomy, avoiding surgery, staying alive, and achieving life goals. And look where, whoops, I'm moving too fast here. And then look where staying off steroids is, which is very important, that we feel this is very important to get these patients off steroids. Look where they have it. The UC patients, only 11% thought that they should try and stay off. And then look at the Crohn's patients. It's 11%, but it's at the bottom of their list. So it's very important to get this understanding also from your patients so that you can educate them on, wait a minute, steroids here? That's extremely important. Look at all the damage and the risks that are involved with that. And we need to get you off. And once again, they're saying, but I feel so well on steroids. So education is extremely key in shared decision making. And here is deciding when shared decision making is right approach for your patient. So you're going to ask them 4 key questions. Is there an established standard of care for the clinical scenario, or is there equipoise? These are questions for you. Then you go, what are the stakes? Is this a decision about which antibiotic to use? Or do side effects such as death and cancer need to be discussed? What, does your patient want to be part of a shared medical decision? And what are the information needs of my patient? So this is the process you would go through in deciding whether this is a right approach for your patient. So the importance of shared decision making, use of biologic therapy. Why do we need it? IBD is a chronic condition. It's characterized by periods of active disease and remission. It's a very up and down disease pattern. Patients need maintenance therapy with combination of therapeutic agents. Biologic therapies are effective in achieving and maintaining remission, particularly in combination, and discussing complex benefit risk profiles of agents, which, with patients is tricky, and it's often a major cause of psychosocial distress for these patients as well. So these are all issues of why it is important. So the use of biologics, barriers may exist in using biologic early in their treatment. Main barrier is concern about side effects. Provider fears them, sometimes for his patient, doing harm. Patients may feel they do not deserve strong therapy. The crowdsourcing we talked about, and the patient not educated or comfortable on risk and benefits. But think about it, patients definitely are more educated today on this. They're getting all this information out there. They want control of their disease. They want the autonomy. And shared decision making engages the patient to make an informed decision that is consistent with their values by asking their preferences. So I think you've all seen the recommendations for how to communicate medical data to patients, and I'm not going to go through these here, but here, effectively commuting risk strategies. Be consistent with your numbers. Use common denominators. Use absolute numbers rather than percentages. 6 in 1,000 instead of 0.006%. I mean, when they've done a study, patients don't even understand, what is that, how much is it? And give perspective by comparing with other risks in life. You have a 1 in 5 chance of dying from a heart disease, whereas your chance of being diagnosed with a lymphoma while on an immunosuppressant is 1 in 1,600. I use the thing, I live in Chicago. Me driving on the interstate in Chicago is a much greater risk than probably any of these therapies, or getting shot, since that's a huge problem in Chicago right now. So you need to individualize and use decision aids when possible. Here's key points in sharing decision. Both Crohn's disease and UC are heterogeneous, so a single treatment algorithm will never suit all patients, right? We saw algorithms yesterday. You need an individualized treatment options, individualized treatment decisions, communicate risks and benefits, allow them to make better decisions based on their personal preferences, and decision aids can help. But also remember, it never takes the place. And here's actually the process of how to implement it. You're going to invite the patient to participate right off. Then you're going to present options, provide information on risks and benefits. You're going to assist patients in evaluating options based on their goals and concerns, and facilitate deliberation and decision-making, and then finally implement the decision-making process. But here's the key. Although all the steps are important, in patient-centered care, step 3 is the most important, and that's where you are asking the patient their preferences. That is the active piece of decision-making. So getting your patients on effective therapy, I'm going to run through this pretty quick. Risk of untreated disease or ineffectively treated disease, that's a huge thing to discuss with our patients. Remember, this is a silent disease as well. Agreement on goals, negotiate trial of therapy, use objective disease monitoring, your treat to target, negotiate follow-up short-term, you're keeping the patient engaged. And you want to reassess disease objectively. You saw this yesterday with David Rubin showing this treat to target process and where the decision-making piece is, but you can see there's ongoing monitoring, ongoing engagement with the patient. Here's that algorithm yesterday on decision-making, where a patient is somewhat refusing treatment. Here's the process you go. First, you're going to look at their fears. You know, is the problem here when you're discussing these treatment plans, is it fear? So you want to acknowledge them. Is it denial? Then you need to educate, maybe a second opinion. Misinformation, you're going to clear up that misinformation with them. And then you go through this process that you see there. Alternative therapy, like if they want to go on a diet. Like some people say, I want to go on a diet. Okay, but we're going to do short-term therapy. We'll try it your way, and then we'll maybe reassess subjectively in 3 months, and if it's not better, we're going my way. So here is shared decision-making strategies. It really is following the algorithm that I did show you there. And here was our question. Can you tell me which one now you think it is? A, raise your hand if you think it's A. B, raise your hand if you think it's B. I'm probably going through them too fast. Well, they got it up there. Good, we've got it. Yes! They didn't have it up there earlier. So, which one do you think it is? I think I've given you enough hinting along the way to answer that. Okay, everybody done? Got it? Okay, all right, won't move ahead till. So see, you have to answer it, guys. Look at this. 63%. They must have got my preferences in there. Good. All right, so the thing is, and I know this was kind of tricky, guys, because when you look at this, all of this is important, right? It's all a part of it. But the only active piece is asking the patient their preferences. That is the active piece of shared decision-making. All right. And here, what can you tell your patients? Be educated about IBD. Use trusted websites, CCFA. I always tell our patients that is your website, main trusted place to go, and don't make medical decisions on your own. Tell them, discuss your questions and concerns with your medical team. Be honest with your concerns and expectations. That's so important. Be realistic with your concerns and expectations. And remember, you need to be a willing partner. That is also extremely important. Be positive. We are in this together. And that's how you tell the patient, this is us together. We're working together to get you well. And that's my team.